Is the talk visible? Hello.
Yeah, it is. Yeah, it's clear.
Thank you, Dr. Rajesh, for the kind words. And I would like to thank Dr. Monica, Dr. Sridhar, Dr. Rajesh, and Tawfiq for this invitation. And thanks for all the help with the IT, Tawfiq. Monica actually asked me to do a talk on neonatal simulation, and she said she wanted it to be very practical. So I thought I'll use this opportunity to tell you how we used simulation in our department in East Lancashire over the last few years to implement various guidelines and to improve practice and to reinforce practice, as well as how it helped us with COVID scenarios as well. So basically what I'll be doing is in the next half an hour, 40 minutes, I'll give a brief introduction on simulation. I will tell how we use simulation to implement a new practice with a certain example of delayed cord clamping. I will also show how we use simulation to reinforce practice by designing a specific simulation course for the trainees in our hospital. We'll also, the last bit will be on how we use simulation to establish COVID protocols. So what is simulation? Simulation in healthcare can be broadly defined as a tool, device, and environment that mimics an aspect of clinical care. It is essentially imitating a real-life scenario and seeing how things work and helping enhance learning in a safe environment so that both the staff and trainees are prepared to handle various different scenarios. I'm going to show you an example of a simulation of preterm resuscitation.
Look at the idea for me.
That's come off.
Okay, just fine. Put in a pre-rectal, please.
Yeah.
Can you have some heart, please?
Temperature probe on.
Okay.
Okay.
So is the baby having any spontaneous breathing at the moment?
He's beginning to breathe. He's a bit gaspy at the moment, but beginning to breathe.
So what's the heart rate, please? Can you have some heart rate, please?
So what you saw in the video is basically a simulated scenario for preterm resuscitation. So there'll be a trained facilitator to help with this kind of a scenario. So why simulate? Many people ask this question. Simulation allows teams which train separately but work together, like the nursing and medical staff who have trained in different roles. They work together to help them work together to train for high-risk, low-frequency events. They help cascade training with regards to human factors, team working, behavior, and interaction. They allow active learning processes through experiential learning, and can definitely improve outcomes if practiced effectively. So what are the different processes we can use? So we can use task training sessions. That's essentially if you want to show a new equipment, you can use task training sessions to show that equipment, skills and rules. Say you want to teach bag and mask ventilation. You can use skills and rules simulations to teach that. You can have departmental simulations with predefined scenarios. And then you can have multidisciplinary scenarios. Say you want to show how you simulate transporting a baby from one hospital to the MRI center or elsewhere. So you can have a multidisciplinary scenario which will involve many teams. Where do you do it? You can do it in a sim suite. The one I'm pointing to right now is a photo of a sim suite. You can have a departmental area converted to facilitate the sim. Like for this instance, this is Southampton's neonatal sim suite. And then you can have in situ, that is at the point of care. I'll talk about this in more detail as we go along. So how? Essentially, any simulation should have a predefined scenario, and then you have a pre-brief before the simulation where you explain what the simulation would be and what mannequins are available, what equipments are available, and how you'd go about it. And then you run the simulation session. And then at the end of the simulation session, you have a debrief. And the debriefing is done in different styles of practice. that it's a separate talk in itself. I would not go into the nitty-gritty of debriefing, but this is what a simulation would essentially entail. Mannequins, you have low fidelity mannequins, simple task trainers where you can teach bag and mask ventilation. You'll have medium fidelity mannequins like the life cast mannequins, which have realistic airways to actually show you can teach intubation and run different scenarios. And then you have high fidelity simulations where you have mannequins with heart rates, respiratory rates, and with where you can change different modalities, the baby going blue, all that can be shown. It is not necessary to have a high fidelity mannequin essentially to run a proper simulation. You can actually create enough psychological fidelity, that is reality, with the right kind of a proper simulation instructor running it with moulage. So now I'll come to how we use simulation to implement different practices. And in this particular instance, I'll talk about delayed cord clamping and how we use simulation in our unit to implement delayed cord clamping. So delayed cord clamping in extremely preterm infants is now becoming standard of care. There is conclusive evidence that DCC reduces inotrope use, the need for transfusion, the incidence of IVH, and necrotizing NEC in preterm infants. If it's used effectively, it reduces the cardiac output as well, and helps stabilize both the systemic and the cerebral pressures. And our team embarked on implementation of DCC in all gestational ages in 2018. Now, this was a new practice. Nobody had done it before. We were doing DCC in gestations about 37 weeks in term babies, but in preterm babies, we had not implemented DCC. So the aim was to make DCC a part of routine care for all births, irrespective of gestational age. So we engaged in a multidisciplinary simulation training program to achieve this. Now, how did we go about this? So previously, like I said, the resuscitation of extremely preterm babies they had immediate cord clamping and then was routinely performed at the resuscitator. We bought 2 LifeStart trolleys to facilitate DCCs. I put a picture of the LifeStart trolley here. So basically, it's a portable resuscitator that facilitates delayed cord clamping while also allowing respiration at the bedside. So this basically provides temperature control. It's a heated mattress over here. And we also have an RPAP machine, which I'll show you in further photos, which will help with respiration at the bedside. Now, this required engagement and training of all staff involved. And in the UK, we have to have at least 85% staff trained before we can embark on any new practice. So how do we go about it? We did multiple things. So first thing what we did was we had a guideline created. And based on the guideline, we started off with teaching how to use the LifeStart. So we had task training sessions. So this is essentially the LifeStart machine, which you can see over here. You saw it in the other photo as well. So where this is a suction apparatus, this is the RPAP machine with which we can give both inflation breaths as well as ventilation breaths. This gives both PIP and PEEP essentially. And this is a heated mattress. And what you see over here, the sheet over here is basically, if you want to sterilize, this is a sterilized cover, what we use when we go for resuscitations in the theater. So we taught staff in these task training sessions how to use this equipment in both birth suits and the theater, how to use the transformer and the thermoregulation apparatus in the machine, as well as how to deliver respiratory support. And this was with the help of simulated mannequins. Then we moved on to neonatal team simulation. So we had large and small group simulation sessions. We used simulated patients as well as colleagues and mannequins. Each member of the team performed their expected roles. And these scenarios were used to demonstrate local guidelines as well as contraindications when not to use it, how to go about doing it. All this was taught to the neonatal team separately in small group sessions. So there you can see one of my colleagues is actually simulating the mother. And then we have a mannequin which is being used to show how to deliver the right amount of inflation breaths and ventilation breaths with the use of LifeStart trolley. Once we got a certain amount of engagement from our neonatal team, We then moved on to obstetrics, anesthesia, and theater staff. So the plan was to cascade training to everybody who would be involved in DCC in the trust. And so then we went to the labor suit. So you can have, this is the midwife actually delivering. We have a Lucina doll, a mannequin, which the obstetrics team used. So we got that through, we got engagement from the team there. And here we are practicing a simulation with the lifestyle trolley and DCC in real time. One of the good things which came out of this session was we were able to fine tune our guidelines as well. We kind of understood that we needed a, say in this scenario, in this labor room, we actually didn't have extra oxygen concentrator. So we needed a split oxygen concentrator and air port valve as well. So we arranged that. So we went into each of these labor suits and tried simulations to see what equipments are necessary and what ergonomics need to be changed to help facilitate this. After the labor suits, we moved on to the theater. So here you can see a full section happening. But again, this is a simulated section. You have a Lucina doll over there, and you have the DCC trolley being shown there. And we ran the session. I'm just showing you different photos on how we ran the session about. So here you can see that the baby has just been delivered by a cesarean section. So that's a simulated mannequin, which is being put into a neo-wrap bag and then moving on to the resuscitator. And here you can see how they're giving the CPAP or ventilation breaths if required using simulation. This is a full picture. The cord is still intact, and we are basically giving respiratory support to the baby at the bedside. Here the cord has been cut and clamped after physiological thing. So we generally do it for 1 minute and more if the baby allows it. And then once the cord is cut and clamped, you move the trolley from here back to the resuscitator. So following multiple task training sessions over a period of 4 months, we hit the 85% target. Concurrently, the departmental simulation team also ran it for the neonatal team, which was going on. And over this period, we implemented DCC in clinical practice by those who were already trained. Deliveries were supervised by consultants who were both proficient in the guideline as well as the use of the life chart trolley. And like I said before, using the feedback, we rearrange the ergonomics of the department. We fine-tuned the guidelines, and from late 2018, we have been doing DCC, and things have been going without a hitch till COVID hit. But even now, we're practicing DCC in all babies. So that is DCC and how we implement DCC. The next bit is how we use simulation to reinforce practice. So we have a unique problem in the UK. I think might not be unique in the UK. It will be in any training hospital where you have trainees rotating every 6 months. We have 2 levels of trainees, the junior doctors who rotate around 4 months, and we have the senior tier who rotate every 6 months. Now, though generalized resuscitation practice are standardized, there are variations in practices among different units. For instance, some places use the Portex ET tube. Some places use the Vigon ET tube. The clamps used to connect these ET tubes might be different in different places. Some places suture ET tubes on. Some places use the NeoFit or the NeoBar clamps. And trainees who have just worked in one unit might not be used to all these different practices. The other thing is the levels of experience of the trainees will be different. Their acumen will be different at different levels, and all of them might not be trained equally in every aspect of neonatal resuscitation and emergency care. Consultants are on call during out of hours, and they have to drive in 10 minutes to 30 minutes drive time on where they live, based on where they live. So the middle grade trainees can sometimes be faced with these emergency scenarios where app management will determine outcome. So we had a think tank of around 3 neonatal consultants and took feedback from colleagues, other consultant colleagues as well. And we thought we would do a bespoke simulation course in our unit for in-house medical and nursing staff to address standardized practice by all team members in preterm and term resuscitations, ensure that all trainees are trained in using the LifeStart for delayed cord clamping and servo control in preterm management. Like I said, LifeStart is not used in all units in the country. Some units are still starting to use it. Some units do direct cord clamping with the help of resistor. Some units are using the Concord vent as well, Concord machine as well. So it's different practices in different units. So we wanted to ensure that all trainees who start with us are trained in using the LifeStart. We also incorporated pneumothorax and difficulty with training during resuscitation. We wanted them to handle unexpected surgical scenarios, which can happen as a non-surgical level 3 unit. So we don't, essentially all surgical cases are transferred across to the surgical center antenatally. Now, at times you have mothers walking in with a gastroschisis or a diaphragmatic hernia and delivering. So we want our trainees to take care of these babies as well as address human factor training in various resuscitation scenarios. So what did we do? We created a resuscitation interest group with 3 consultant facilitators leading this group. And then we devised a 1-day simulation study course, which included high frequency, high risk, that is common events, and low frequency, high risk scenarios as well. So extreme preterm resuscitation of a baby with a pneumothorax, resuscitation and stabilization of unexpected surgical scenarios, which included gastroschisis and congenital diaphragmatic hernia, and resuscitation of a baby with no cardiac output. Each course was designed to have 8 participants and run every 8 weeks. We had 1 middle grade doctor, 1 Tier 1 doctor, or an advanced neonatal nurse practitioner, 1 senior nurse, and 1 junior nurse or a midwife as part of 1 team. And so we had 2 teams running, being trained in every course. We started this around in early 2019, and we have had around 7 study days so far. There was a miss of a couple of study days because of COVID, but then we have now continued with adequate safety practices. So the initial courses, we gave brief lectures followed by sims, which involved a pre-brief, simulation, and debrief using the advocacy inquiry or debriefing with good judgment technique. After that, we obtained feedback after the first couple of courses, and the trainees told us that they wanted LifeStart. They wanted to know how to use the LifeStart. They wanted also to understand how to use a video laryngoscope. They wanted separate task training sessions on insertion of a chest train and servo control and preterm resuscitation. So then we started in the future courses, we started having task training sessions for these procedures as well. So here you can see one of my colleagues actually training trainees on how to use the video laryngoscope. You can see the video laryngoscope here and how they are using it. So what we did after the feedback was that we started running all the scenarios twice. So during the first attempt, the facilitators used something called rapid sequence deliberate practice with start-stop session. So the session will start, and then if we feel that something needs to be addressed, we stop it there. We then give them a directive debrief or a feedback on how things went, how things could be done differently, and then we restart that session from the start. So they kind of got multiple small sessions during the whole scenario. And the second attempt was the same scenario run in its entirety. And then we finished that off with an advocacy inquiry debrief. So this is after COVID started, one of the courses where we are doing debriefing. You can see me there and my colleague who are facilitators along with the participants running a full advocacy inquiry debrief at the end. We've had a lot of positive feedback from the course, from the trainees. We looked at the average confidence levels. Pre-course was around 6.1 out of 10, and the post-course we got trainees ranked their confidence levels at 9.2 out of 10. This is a word out of all the feedback we got from the trainees, and you can see that good and useful being the most common words being used. So the key message from what we did and how we did the NRIC courses, you have different courses, but then a bespoke course to train both rotating and permanent staff in advanced resuscitation scenarios in a standalone unit is feasible. And this will enhance confidence among both staff members, especially consultants who are on call at home, and invariably improve neonatal outcomes. And then, how did we use simulation to get our way around or still going through the pandemic? So the COVID dilemma. COVID hit us in March in the UK. I think it hit different countries at different points of time, but we faced the brunt and all the challenges was started off around mid-March. So what did it bring along? It brought in change. It brought in the virus, as well as it brought in change in usual practice. We had to create a framework for practice. We had to implement that framework, and we had to ensure that it was safe when we were implementing things. Now, and all this had to be done at breakneck speed. So how did we go about it? What are the changes in practice? So we had to receive the baby in a separate area from the mother. Life start had to be deferred. Resuscitation needed to be done with full PPE. Use of a dedicated transport incubator for moving suspected babies. And the more senior staff to attend to reduce exposure, and less number of staff to attend high-risk scenarios compared to previous when you had many people helping out. So at that point of time in March, there were not too many guidelines, or there were no previous guidelines at all. The British Association of Perinatal Medicine started off with some webinars on basically how to go about dealing with these babies being born to suspected or positive COVID mothers. And they brought out some resources as well. The NICE got out some guidelines. The Public Health England also gave some guidance on how to don and doff. There were guidelines coming out of the European Research Council as well. So what we did was we identified key personnel. We nominated a COVID guideline lead. We had a nominated PPE advice lead, because things kept changing. When to use the right PPE, in which scenario use what, is this process, or is high flow aerosol generating procedure? Half the people didn't know. So we got a nominated PPE advice lead to help fine tune and streamline that. We got a nominated nursing team lead who specifically dealt with COVID scenarios. We then had multiple MDT meetings with anesthetic, obstetric, and theater staff. And guidelines were then quickly created with the available evidence, which the guidelines incorporated multiple clinical scenarios. I think there were around 8 or 9. It also had scenarios on how to don and doff. There were lots of flowcharts and diagrams on how to go about it. And the social distancing policy in all areas were predefined. We also created a task force and had regular meetings. The consultant and senior nursing team had regular meetings to see how we're progressing with stuff as well. So once we got the guideline ready, then the dilemma was, how do we test this guideline? How do we and once we have the guideline in, how do we percolate this guideline to the staff quickly and effectively? Things kept changing at rapid pace, and keeping the staff informed and informing them was a challenge. And then would we be able to run simulations? How would we go about it? So again, the implementation dilemma. Do we do in situ simulations? Do we do otherwise do we run it in a sim suite? Can the in situ simulations be done? How do we go about it? So what are in situ simulations? I briefly touched about previously, but these are simulations run at point of care. They're excellent for evaluation of systems and processes, but can be disruptive to the area of work. Now, we were not very sure whether we can use in situ simulations or not, but we went ahead. So we created, the major scenarios we created were these 4: COVID resus scenario in the theater, a COVID resus scenario in the birth suit, a postnatal collapse scenario, and a dope scenario in COVID isolation room. We got multidisciplinary involvement with the neonatal consultants, nurse educators, ops consultants, midwives, theater managers, and postnatal matrons being involved. As a consultant body and nurse educator team, we ran a trial first to see how all these 4 different scenarios worked. And then we looked at the learning points, and there were a huge number of learning points. We understood in situ simulation can work. We thought that PPE is a stumbling block, but we kind of went around it. We also understood traditional debriefing, because these scenarios are long. You have to, it starts off from a crash call from a crash call going off saying that there's a COVID baby being delivered, and then it goes all the way up to the theater or the birth suit, and then the scenario happens there and then finishes off, and then all the way the baby is moved down into the isolation room. So these scenarios are long. So traditional debriefing, we understood is not working. And there were huge number of learning points. So outcomes from the trial run, who do we need to train? We'll need to train all staff attending the COVID scenarios. What do we use? Do we use high fidelity, low fidelity? We understood high fidelity mannequins are difficult to use. So low fidelity mannequins were planned to be used. There was this question of when do we start? Do we start straight away? Or do we address all the issues before you go? We thought we need to start straight away and then address issues as we go along. So how did we go about it? We went on with in-situ simulations. Each scenario was broken down into micro sessions. And then we had a mix of stop, start, stop, restart sessions. This experience helped us change our style of running the NRIC course as well, which I talked about previously. We had modified rapid cycle deliberate practice with directive feedback. I'll talk about that in the next slide. And at the end of the whole scenario, we had a very short 5-minute advocacy and query debrief at the end. So what is rapid cycle deliberate practice? Essentially, you are a novice performer. You run a session, and you're given a brief feedback. Then you become competent. Again, the session is rerun, and you're given a brief feedback. You become proficient. Again, a session is run. You give a brief feedback, and then you become a master. Once you become a master, you increase the level of difficulty, and then you still, if the level of difficulty is increased to a level, to a certain level, you might become a novice again. So this is what is called rapid cycle deliberate practice, and it has come a lot into resuscitation debriefing nowadays and simulations. So the sims, we ran multiple in-situ simulation sessions. We covered 72 staff in the first few weeks. Learning sim points from every sim was collated and sent to the sim lead. That was me. Sim action matrix was created and updated on a daily basis. Now, what is a sim action matrix? This is something which I'm proud of. What we did is we created a sim date. We created issues identified and say this is a sample where we say trolley beds were in corridor. So we had to talk to the theater in charge who had to sort that out. So we put an action plan in place. We arranged somebody to undertake that action and put their name involved. And we saw every day how things were being resolved and new things being cropped up. So this is still ongoing. So in summary, if you are running a scenario or if you're creating new practices, you have to establish a clear plan, get the wider team involved. If it's a new practice, always have a trial run before you start running it. In-situ simulations work well to establish guideline change. And for those people who are already simulation instructors, try exploring different debriefing styles. Thank you. I'll leave you with a photo which came out from a unit and which went viral around the world. Some of you might have seen it. Thank you.